Alzheimer's disease being one of our last two topics, and not being immediately related to depression, but also a cognitive disorder, and there are a few usual suspects that come up in this section. And I'm not trying to say that there are parallels between the two or that one begets the other or causes the other, but it's interesting that some of the same players are evident as we go through this discussion. Largely, Alzheimer's disease is probably one of the most common forms of cognitive deficit that you observe when you get older. And it's not the only hallmark of aging. Aging is going to be the next topic that we discuss. And I know there is an entire new fourth-year course on aging, which is it this semester or is it next semester? Okay, so maybe this is a good preface for that course. It's not going to cover a lot of the same material. I like to think of it as sort of a theoretical, philosophical perspective on aging. Why do we age? It's a good question. We just assume that it happens. So we're gonna talk about that a little bit. But aging is characterized by decline in many different areas, Alzheimer's being one of them. Increased prevalence of diabetes, cardiovascular disease, bone mineral density goes down, frailty, balance are compromised, muscles begin to waste, and oddly enough, aging seems to be a program. So this is a preface for next week, but we seem to age on purpose, which doesn't sit well for a lot of us. Maybe not you because you haven't started to age yet, but when you begin to age, that it's on purpose doesn't really sit well. Why would that be the case? Why wouldn't we just stay healthy for a long period of time? So aging might be programmed. The mechanisms, we're deciphering them, and that's one of the big questions of biology. One of them is how the brain works. Another is how we age. It's up there with are we alone in the universe, but for biology. So we're deciphering the mechanisms. Some of them are similar, and their effects are different because they occur in different tissues. Now, this is in its infancy. Alzheimer's being one of the symptoms of aging, the treatment of Alzheimer's, the treatment of other conditions, and the treatment of aging is largely focused at the symptom level. So can we treat Alzheimer's? Can we treat muscle wasting? Can we treat diabetes when those might be a symptom or a cause of some larger program? And so there's some context being added here. Maybe if we could treat the underlying disorder, not the symptom, perhaps we'd have more success preventing these individual diseases. But that's a topic for next week, so we'll get there. All I want you to understand in this section as we introduce Alzheimer's, it's a part of aging, and it tends to increase in prevalence, or function tends to degrade more as you age, along with the functions of all the other systems in the body. Blood, muscle, heart, nerve, respiratory. Of the maximum function you observe in young adulthood, they decrease over time so that they tend to be minimally effective as you get older. And eventually one or all of these will cause the system as a whole to stop functioning. So many different areas of the body all decrease in capacity. Nothing tends to go up as you age. And this is not any physical metric. This is just percent of total function. Think of it that way. Percent of maximum function. If you could measure any of these things directly, like maximum heart rate, you'd see the same thing. One of the things that we can measure is VO2 max, which is a really nice gold standard measure of the cardiorespiratory functioning, of muscle respiratory capacity, and again, universal decrease as you get older. And not only does it happen for the average individual, those that are sedentary in the dark squares along the bottom, but it happens for those that are physically active and those that are highly active. So you can't escape, which is unfortunate. There's about a 10% decline per decade in VO2 max, and that's meant to represent the deficit in underlying function of the respiratory system, the cardiovascular system, the muscle, perfusion of the arteries, endocrine function, nervous transmission, all the things we listed on the last slide, about 10% per decade after 25 years. So you're right on the cusp of experiencing this. I've experienced my first 10%. It's not fun. And it's only downhill. Yeah, question?
So the 70 milliliters per kilogram per minute, that seems very high.
It is very high.
Okay.
Yeah, so that is your endurance-trained elite type athlete.
Like elite athlete.
Yeah,
Okay.
yeah. Highest relative VO2 max I think recorded is 104,
Yeah.
which is abnormally high. When you say endurance trained, often you'll give 65 to 75 as the range. Recreational somewhere in here, and then sedentary 45-ish or so. Yeah, very high. Yeah, so that's the caliber of athlete that we're considering when we talk about endurance trained. Even they go down. Importantly, these are similar slopes, so similar rates of decline, but you can move between groups. So it's not that if you're sedentary, you're destined to go down along this curve here. You can become more trained and then endurance trained as you age, and your personal slope might be an increase in fitness over time, but for the general population within one group and not actively trying to change groups, you can buck the trend a bit, so to speak.
So it refers more to like a theoretical maximum VO2 max, whether you train for it or not.
This is observational cross-sectional data. So people of a certain age that are considered endurance-trained, active, or sedentary, these are measured VO2 maxes in those individuals for a given age. And so we expect that these relationships will hold true if nothing else changes. If age is the only thing that changes, you'll follow this curve. If age and training intensity change, well, we don't know what that curve looks like. Yeah, it's a good question. The majority, I'd think, might be active or maybe highly trained and then become more sedentary as you get older, which is an even steeper decline. So that's something to be aware of.
And would these have been the same people over the 50 years or whatever?
No, this is not a longitudinal study, just cross-sectional. Yeah. So this is what we have to look forward to. Now this is the organism as a whole, but this section really wants to focus on cognitive function, the decline in cognitive function. And we don't have a nice curve like we do for VO2 max because cognitive function is not something that we have a standard test for. It's not well defined. What is cognitive function? The ability to think or process or remember or speak properly or coordinate tasks, move around. Cognitive function is a pretty broad umbrella term. We do describe levels of cognitive function using a few tools that I'll get into in a second, but we have broad classifications from normal function to compromised function. And compromised function generally is described by the term dementia, which literally means without mind. And this is a class of cognitive deficits, of which Alzheimer's is one. So dementia is the metabolic syndrome of cognition. Yeah, sir.
I'm sorry, I have my voice.
No problem, me too.
Know what the physiological difference between Alzheimer's and other forms of dementia is?
We don't have a satisfying answer for that, but I'm going to go into depth of what we do know so far of the progression of Alzheimer's and dementia, and a few of those characteristics are shared. There are other subtypes that are less well known and more rare, where function is compromised in a similar way but through other mechanisms. And that might not make a whole lot of sense now, but I'll show you what the usual suspects are for Alzheimer's specifically. The difference in function between dementia and Alzheimer's I'm not that well versed on, but I think of dementia as the precursor to Alzheimer's, and that's a specialization of cognitive deficit. So you are getting kinesiology degree, but if you went into your master's or PhD, you'd specialize in one type of science, metabolism or some clinical aspect. Right now, you're getting the dementia equivalent of education, and you'd specialize in the Alzheimer's aspect later as you went into grad school. So dementia is broad, meaning without mind, and we try to characterize it as some facet of cognition is compromised, whereas Alzheimer's specifically relates to memory, behavior, and thinking. It probably does cross over into other intangible measurements of cognitive function as well, but the way that we describe it, it's a deficit for newly learned information only. People with Alzheimer's tend to remember their 20s and young adult years quite well. And it's newly learned information, so it's the formation of memories, the processing of information that is somehow disrupted. And we don't exactly know how that happens, but some things always tend to occur, and so we're looking in those regions for therapies and to understand the mechanisms of Alzheimer's specifically. So Alzheimer's, a specific type of dementia, an advanced progressive type of dementia, which typically occurs normally after 65 years old, but it can occur, cognition can decline earlier than that, and there are large genetic supports or inroads for early onset Alzheimer's, which typically happens 58 or 60 years old or later, before 65.
Is that just for Alzheimer's or for all?
This is just for Alzheimer's, yeah. Yeah. Yeah, dementia is a non-specific disease, overall term referred to as an umbrella term describing a wide range of symptoms, including a decline in memory, poor judgment, decreased focus. Alzheimer's is one type of dementia, but not the only type. It's the most well-known type, but not completely characterized. So there's Huntington's disease, some vascular disease, Creutzfeldt-Jakob disease, Parkinson's disease are all types of dementia as well. And that's taken from Alzheimer's.ca, because I didn't understand the difference either, so I wanted to help describe that to you. But Alzheimer's, the most well-known type of cognitive decline, or at least the most well-characterized. Yeah?
So is there like an umbrella age for dementia onset, like regardless of what kind, or do each one of those disorders have, like does it have its own particular age range for
That's an interesting question. Is there an age of onset for dementia? And I don't think that we can specify an age because the transition is incremental, it's progressive, it's not immediately obvious when things start to go wrong.
Yeah.
Everybody forgets things, right? Think about any test performance that you've done before. You forget some information, and so when is that forgetfulness from not studying or not being so exposed to the info, and when is it because of some deficit in cognitive function? It's really hard to define that limit. So I don't think we have an age that we can say is when dementia develops, but we do have ages when Alzheimer's develops because it's more obvious. The types of deficit is more obvious. Yeah, sir.
There's also categories of early onset dementia, so even if there was an age that they generally sort of sink in, it can happen way earlier anyway.
Okay. And what ages would that be? Do you know?
I believe that's under 60.
Under 60, so similar with maybe a 5-year gap.
Yeah.
Okay.
I know there's a couple people at the home that one of my grandparents is at that had it at 40.
Wow, okay.
Yeah.
That's really interesting because how do you diagnose it? Right? And that's what
They need like a brain scan.
that's what we're getting into now. Like it's such a complicated series of elements that make up cognition. So it must be an equally complicated number of tests to diagnose that function. And is it a structure-driven change? So is it a brain change itself that underpins function? Or is there something else, the linkages between the brains that might not be borne out just in volume or firing? And do we have the technology to be able to measure that? We have some, and I'll show you coming up what we know so far. But it's a really difficult area to study.
I was
Yeah.
just gonna ask, do you know if there's a pretty heavy genetic component to it? Like, would it be possible for early screening the same way that you do with breast cancer or?
There is a heavy genetic component to early onset Alzheimer's, and I'll talk about that coming up. Yeah. Yeah, a very convincing genetic component of early onset. So we have all of these aspects that might be considered brain function or cognitive function. How do we test these? How do we test brain function? We can do cross-sectional studies like we looked at initially, take people across the age range and measure cognitive function however we decide is the best way. We might be able to do a longitudinal study where we take those people and administer the same tests throughout. Can't do crossover studies. Interventions are really hard. A lot of the information that we have is not causative, and therefore it's hard to draw conclusions. You can't do a crossover where you give someone Alzheimer's and then reverse it and see if the same thing doesn't give them Alzheimer's later. You can do group-matched clinical intervention studies where if you have two groups of a similar age with fitness characteristics and anthropometric data, you can give them two different interventions and see if one preserves function for longer. But it's not perfect because they're different people. Then, what is the intervention and what are the tools used to assess attention and language and problem solving and executive function, which are control of all of these other elements? One of them that is more commonly used now is called the mini mental state exam, and this is becoming the standard method of cognitive assessment for dementia and Alzheimer's patients. And it's pretty straightforward. It takes 5 to 10 minutes, only 11 questions. You can see it scored here. Asking questions related to a whole host of functions: recall, orientation, attention, language, and the types of questions you can see here. What's the year, season, date, so memory, give you the name of 3 things till you remember that list. How long does that take? And then we follow up later. I gave you the name of 3 things a couple questions ago. What are those things? Can you follow instructions to fold a piece of paper and put it on the floor? So does the coordination and the translation between receiving the instructions work to execute a task? So this is how we try to get at cognitive function overall. Many different aspects of what you might call brain function. And this is standardized. Maximum score is 30. Anything under 23 is considered impaired. And the lower the score, the greater the impairment.
So, how do, like, if I were to get a bad concussion, I wouldn't be able to answer a lot of these as well.
It's possible.
So, how do you know somebody's early onset or just has had repeated concussions, like CTE or something, or even at that point just has one bad concussion at that point?
And how do we know that repeated concussions aren't early onset?
Yeah.
What that might predispose you to cognitive dysfunction. So
Okay.
I'm not sure how you would
Yeah.
differentiate between different types
Okay.
of cognitive decline, but maybe just the fact that cognition has declined is enough. And then there might be MRI scans,
That's kind of
fMRIs to evaluate the function of the tissue itself that might differentiate scores here from dementia versus some other external stress or impact.
I feel like that would be something you'd be asked as well going into something like this.
There'd be lifestyle questionnaires and context, absolutely, yeah. And the rough age grouping might help as well. There are specific concussion tests. This is one that I used in my doctoral degree just to measure cognitive function. A battery of tests, 8 different kinds of tests. This is the immediate post-concussion assessment and cognitive testing test. And you do a series of baseline tests here, followed by another series after a concussion, and then through follow-up to see if you're ready to return to play. And the tests are similar to evaluate cognitive function. So this one, for instance, you're shown a number of symbols, And then these don't change. This symbol here is the operative symbol. You have to hit the key, the number that corresponds to the symbol, and then it changes with a given time frame, 1, 2, 3 seconds. And you do 30 repetitions, and then the symbols disappear. And then you have to still hit the number corresponding to the appropriate symbol, and you're given a score for the correct answer or the time to respond. And then other tests like this, you're given a list of different symbols, and you have to memorize the list of symbols or see if they're familiar. And then after the testing's done, was this one of the designs displayed? Yes or no? If it was, or if it wasn't, and you answer correctly, you're scored appropriately. Number of different tests like that. Some that we use currently in the lab are Stroop Test, or you might have heard of the Stroop Test before. Processing, executive function, distraction. So this is a visual version of the Stroop Test where you're given the name of a color but written in a different color. So the word orange here is written in red. You have to go into the list and find the word red, which is written in yellow. And so you find the word red, and then this is just done on like an iPad, and you click the button, and then the next one changes, and you're scored appropriately, and they come faster, and you have a certain number of strikes. Or you can do it verbally. There's a whole different, there are different varieties of Stroop Test, but this is how we can try to evaluate different aspects of cognitive function, and hopefully evaluate change over time or just a deficit as you age. So those are the types of tests that might be used to evaluate cognitive function. I'll talk about some of the external brain scans shortly, but those are the types that you might administer to evaluate cognitive function in a research study, for instance. So the way that the rest of the lecture will go is I'm going to focus mostly on Alzheimer's as a flavor of dementia. There are a few slides where poor choice, yeah. There are a few slides where we do look at some dementia-related scoring or incidence of dementia as a way to try to build our case for exercise and its impact on Alzheimer's. But really, we're going to try to characterize Alzheimer's disease itself as one example of dementia and go from there. And many of the mechanisms overlap. And largely, we think that cognitive decline is in some way related to the accumulation of these plaques, these aggregations of proteins within and between the neurons of the brain. So specifically, these are beta amyloid plaques, meaning that these are clumps of protein made of individual beta amyloid proteins. So each of these rods is one beta amyloid protein. And then when they group together and can't be degraded, they disrupt normal function. But the kicker is that this happens normally. And we actually think this is part of the normal formation of memories. We accumulate beta amyloid protein, we make it normally, it aggregates and can be degraded, and we think that it modulates the firing of neurons and nerves and helps to retain information. But when this process is dysregulated, that's where problems occur. So that's one of the hallmark features of Alzheimer's. What I mean by that is if you look at someone who's exhibited cognitive decline and they're classified as having Alzheimer's, if you are ever able to scan the brains or look post-mortem, you find these neuritic beta amyloid plaques, and you also find what are called neurofibrillary tangles, which are related to another protein called tau that I don't even understand that well, but we're going to leave that for the experts. These two things are characteristics that disrupt normal nervous firing. Both are related, at least initially, to the aggregation of beta amyloid proteins, and then how they accumulate determines whether or not plaques are evident or these NFTs related to another protein are prevalent. The thing is, we don't know how they translate, how the aggregation of proteins translates into a decrease in cognitive function. We're still learning that. It might be free radicals, it might be impaired signal transduction, it might be degrading the neurons. We don't really know the mechanism. But it happens. It happens more as you get older, and it seems to happen universally. If given enough time, most everybody would develop or exhibit plaques like this. And it seems to only be more obvious now as the lifespan has increased and we're giving people more time. In distant history, people would have died earlier, and so you wouldn't exhibit cognitive decline and Alzheimer's as readily. But now that modern medicine is caught up and the physical body can live longer, we're starting to observe these changes in cognitive function. So everyone seems to accumulate this at varying rates, but eventually. It's not typically genetic, but early onset is. We have a few candidate genes that are related to early onset Alzheimer's that are involved in the handling of these plaques. And I'll show you a specific example of that coming up. But if you encode a protein that's slightly a different shape, that doesn't handle these plaques as well, you're more likely to develop Alzheimer's early. The aggregation accelerates. What we do know so far is where beta amyloid comes from. It's part of what looks like a receptor in the brain, and it's always cut out of that protein. So beta amyloid is, again, the green rod, and it's removed from this longer protein called amyloid precursor protein. And it happens constitutively, always. We're always producing beta amyloid. We're always cutting out this protein from the precursor protein. And if it's involved in the formation of memories, that makes sense. We're always forming new memories, right? That's a big if. So we're always excising this protein. The problem is when it's not cleaved properly. There's a right way and a wrong way to do it. So amyloid precursor protein, we're not really even sure what that does. It's part of the membrane of the neurons in the brain. It's a protein that spans the membrane. And I have it on the next slide. Yeah, it spans the membrane. It's not just anchored to the surface of the membrane. It spans the membrane. It might be a receptor. We're not exactly sure, but it's always cleaved to release beta amyloid. The proteins that cleave amyloid precursor protein should be positioned in a certain way for beta amyloid to be cut out correctly. When they're not positioned in a certain way, that's where we have a problem. They're positioned by another transmembrane protein called presenilin. Presenilin. It grabs, it anchors the amyloid precursor protein. It positions the scissors to cut out beta amyloid. And if those scissors aren't positioned properly, then the beta amyloid protein is not shaped properly. And it's not even a large change. It's not a large mutation that needs to occur for this to be processed incorrectly. Normal beta amyloid proteins are 40 amino acids long, produced normally, handled easily. Abnormal beta amyloid proteins are 42 amino acids long. Two different amino acids are appended or not cut out, and that slightly longer protein is more difficult to degrade and is more likely to accumulate.
Does it matter which end of the chain those amino acids are left onto?
I don't know the answer to that. I don't know if it matters which end of the chain, but if it's a common mutation, it would always be the same side. It wouldn't vary.
Okay,
Yeah. So a schematic of how this might work is shown here. And there's a lot on this slide, but just notice the usual suspects. So this curly bit is amyloid precursor protein, APP. Transmembrane protein, extends out. We're not really sure what it does. And then we have two secretases, two enzymes that cleave that protein. One's out here, not really a problem, but the gamma secretase site inside the membrane is the one that typically moves, is the one that's responsible or anchored by presenilin, which is the big pink ribbon across the plasma membrane of the neuron. So you can see how it anchors APP. It would position the enzyme to cut it, and if this is shaped somewhat incorrectly, it won't cut beta amyloid properly. It won't cut beta amyloid properly. But it happens all the time. We always make this protein, it's processed, and we're not going into detail about how it's processed, I'm not even sure. It's released from the neurons. It starts to form fibrils, and they link up and they aggregate normally, but it's when that aggregation is abnormal, accelerated, or resilient, resistant to breakdown, that these negative side effects happen. So we have the development of plaques that you can observe at the whole brain level. These are large pockets, aggregations of beta amyloid plaque. Somehow this also hyperphosphorylates, I mentioned that tau protein, to create these tangles that are also evident in the brains of individuals with Alzheimer's. And we think oxidative injury might play a role as well. We're not really sure how it affects or regulates the health of those neurons, but ultimately the overall effect is dementia, decrease in cognition, changes in behavior, possibly due to death of the neurons or neurotransmitter defects. This is what we observe at the whole body level and that we try to approximate with questionnaires, which when you look at it like this seems not the most appropriate way to do that. You're missing a lot of steps. Now I want to point out on this slide while we're here, we have our typical candidates, the tangles and the plaques. I want to point out apolipoprotein E, which is the genetic link or the strong genetic precursor to early onset Alzheimer's. Apolipoprotein E normally breaks down these plaques. It handles the aggregation of beta amyloid plaques between the neurons, and its job is to help dispose of them. Or maybe not dispose, because that implies they're always bad, but degrade them when needed. Think about it that way. It's the breakdown part of the turnover, the normal turnover that occurs. So apolipoprotein E would normally degrade these plaques and ideally prevent the rest of this flowchart. We'll come back to that when we talk about the genetic implications a little bit later. Plaques, tangles, hallmarks of Alzheimer's disease result from the improper cleavage of APP and the improper or accelerated aggregation of beta amyloid proteins. That's as far as we know so far. Yeah, Peter?
It says there neurotransmitter deficits.
Yes.
So would that be have like the relation to like depression?
Very possibly. It could relate to depression if these are the same neurotransmitters or they have influences on like our monoamine neurotransmitters. I don't know if the emotional feelings of depression necessarily translate one-to-one. It could be that they're also involved in memory formation. It could be a link. I don't know if it is or how concrete a link it is, but absolutely it could be. I don't know for sure.
The plaques and the tangles, could you see those with the naked eye? Like if you were to do like a cross section?
I don't think you can see them with the naked eye, but you can see them under a microscope. Yeah. Yeah, you can see them. Absolutely. There's also some parallels between this and mad cow disease. You see some of these features in the brains of cows with mad cow disease as well. Not to say that that's the case for humans, but just that it might manifest in slightly different ways. And it's all a dysregulation of memory, behavior, cognition, etc. I don't know if both have to be present or if one's more present than the other, and that changes the overall whole body results. I'm not sure, and I don't think we know. But this is what we know so far. There's a lot that's more complicated than I think we can decipher. So with that rudimentary understanding, the good news is that we don't have to stop the investigation of whether exercise works. We can look and see if exercise does help to protect against or reverse Alzheimer's, to protect against or reverse cognitive decline. Is there anything that we know about how exercise impacts cognitive function in older adults? And we have a series of some longitudinal, some cross-sectional studies comparing exercise versus stretching, or exercise versus a control. And I'll show you some of the results coming up to try to build a case for why exercise is a benefit to individuals with Alzheimer's. And this is one of the instances where we're using dementia as a precursor, just general cognitive decline. And this is in healthy individuals over time as they develop cognitive deficits. This is a Kaplan-Meier survival curve. So what this shows is the number of individuals left over at a given time period. So right now, at the start of the investigation, all of the individuals were healthy without dementia. And then as we progressed through the study, longitudinally, these curves decrease as people develop dementia. So fewer individuals are dementia-free as you get older. There's some promise for being active, for exercising. Those that exercised over 3 times per week with no idea of volume or intensity, but were just physically active, at all time points had a lower rate of dementia. Were more likely to be dementia-free. So it suggests some benefit of exercise, but importantly, the curve still goes down. So even exercising 3 days a week makes you more likely to be dementia-free, but it doesn't prevent the incidence or development of dementia completely. And I'll show you similar results for the specific case of Alzheimer's, but cognitive decline occurs no matter what. It seems to occur, the occurrence is less accelerated, less severe with exercise, but it seems to occur no matter what. We can look at some of the mechanisms that we just proposed on the last slide to see if they might mediate these changes. We can't do that in humans too easily, but we can use transgenic mouse models, and we have Alzheimer's disease mouse models that exhibit cognitive decline. And we can measure beta amyloid or phosphorylated tau or neurofibrillary tangles, but we think beta amyloid is one of the key proteins or methods of dysregulation that allow Alzheimer's to progress. And if we have these Alzheimer's mice exercise, we'd expect a decrease in the whole body incidence of dementia or cognitive decline, and that's paralleled by a reduction in the beta amyloid in many different areas of the brain. So perhaps the higher incidence of being dementia-free is related to this decreased accumulation of beta amyloid. Now that's a big stretch. The last one wasn't Alzheimer's, it was dementia. It was in humans, not in mice. We do see changes in humans. We can measure beta amyloid, circulating beta amyloid in humans. I'm hard-pressed to say that circulating beta amyloid is representative of beta amyloid in the brain, but if it is, exercise reduces circulating beta amyloid over 6 months versus a stretching control. So maybe that's one of the mechanisms for exercise to protect against dementia, to protect against Alzheimer's. Notice, though, we see 40 to 50% decreases in the brain, 6% decrease, 25-30% net difference between these two groups in humans. So whether it's less effective in humans than in mice, whether measuring in the blood versus in the brain is one of the disconnects, we're not sure. We can't compare these one-to-one, but the message is promising. Beta amyloid seems to go down. That might be a way that we preserve cognitive function. You have a question? Are you good?
Oh, I'm good.
Oh, okay, you're stretching?
Yeah.
All right. So we see some decreased incidence or a slowing of cognitive decline. It might be due to beta amyloid plaques or the reduction of beta amyloid proteins. What's really interesting is on the genetic side, when we look at apolipoprotein, there are many different kinds. There's E1, E2, E3, E4, and they're just part of normal cholesterol. Lipoproteins are just a lipid and protein ball that helps to carry unprocessed fat between tissues in the body and the liver. You have VLDL, LDL, HDL, you've heard of those before, right? So apolipoprotein is one of the proteins on the surface of those cholesterol molecules, and they help to process fats and other intermediates and help to break down these plaques in the brain. We aren't exactly sure how the breakdown occurs, but they do signal the LDL receptor, and there might be a method of signaling to help degrade these plaques, whether it's done immediately by the lipoproteins or if there's an intermediate, we're not sure. But we do observe the breakdown of these aggregated proteins when we induce or activate apolipoprotein E. And that breakdown is best with E1 and progressively worse as you get towards E4. E4 is least efficient. So there's some deficiency in this protein that prevents it from effectively breaking down the beta amyloid protein aggregates. And so this is a genetic, based on DNA, a genetic program or a genetic shortcoming that you can screen for. If you have this gene, ApoE4, that codes for the least efficient breakdown protein, you have a 10 to 30 time or 10 to 30-fold increased risk of developing Alzheimer's. It's not guaranteed. As with anything, there's never one clear answer. But those odds are not in your favor. 10 to 30-fold increase is not good odds. But there are individuals that have the E4 allele, that code for the inefficient protein, that don't develop Alzheimer's by 75. There are some, and they're the exception, not the rule, they're in the minority for sure, that don't develop Alzheimer's. So there are other things that are going on, and this isn't the only determinant of Alzheimer's disease or cognitive decline. So there must be something else. We even observe that a third of the individuals with Alzheimer's are those that are E4 negative, so don't have the E4 allele. The majority are related to the development of this E4 allele, this genetic predisposition, but some of them don't. So something else is going wrong. We're not really sure what that is. But good news is that exercise protects against this genetic limitation. And these are in humans. This is a method of measuring in vivo amyloid burden. I'll put it that way. The amount of amyloid protein. And it's not plaque specifically. So that's an important caveat. It's not measuring plaque formation or size of plaques. It's measuring the burden. So the appearance, the volume, or the load of beta amyloid in the brain. And you could see a typical characteristic response where you have 200 adults between 45 and 88 years old with or without the mutation that either exercise or not. And if you just focus on here non-exercisers that are E4 negative, so they have regular working apolipoprotein E4, they have a low burden compared with those that are E4 positive, that have the deficient allele, where E4 isn't, or sorry, beta amyloid isn't broken down as readily, and there's a much higher amyloid burden, many-fold times greater. And that's what you would expect based on our understanding of this genetic link. If you're E4 positive, you can't break down the amyloid beta plaques as well, so you have a lot more of them. But what's really good, what's great news, there's two pieces of good news. In the individuals with that deficient allele, exercise reduces the amyloid burden. Somehow, the mechanism, or some mechanism related to exercise, clears out beta amyloid proteins in the brain, or it reduces the production of beta amyloid proteins in the brain, or just moves them from the brain. We're not really sure what happens, but if beta amyloid is a precursor for Alzheimer's, removing them from the brain is good. So exercise helps to do that, even in individuals that are E4 positive. But the only benefits aren't seen there. You still see a nice reduction in healthy individuals, which is promising if you think that Alzheimer's is naturally going to occur if given enough time. It seems to be, I don't want to sound too absolute, but it seems to be more likely than not. But we still see this protective effect of exercise in healthy individuals. So we're not sure of the mechanism, but we're sure that exercise works to help clear out the amyloid burden. Now, the brain is one of those tissues where, well, a lot of the tissues in the body are defined, or where structure is closely linked with function. And so the brain, being difficult to study, we can try to measure using fMRI scans, or that last example, which is very complicated that I'm not going to go into depth on, to measure normal functioning in vivo and approximate cognitive decline that way. We can also measure structure of the brain, atrophy of the brain, size and density of neurons in the brain, and estimate function accordingly. And we typically see decreases in brain density, white matter and gray matter, as you get older. The lighter peaks, or the lighter areas here, are areas where decline or atrophy is accelerated, where brain tissue is smaller or reduced. And you can see it in the prefrontal cortex, the parietal cortex, the temporal cortex. So across the brain, age seems to impact these tissues, and they get smaller, they're reduced. And if that structure is linked to function, this could be one reason why Alzheimer's progresses. Conveniently, those same areas are preserved in individuals with a higher fitness. So those individuals that have a higher VO2 max show less atrophy, show bolstered areas in the prefrontal cortex, the temporal lobe, the parietal lobe, and they overlap almost one-to-one, gray matter and white matter. The more green areas are better preservation on the right-hand side. And you can see the green areas match up with the white areas on the left pretty well. So those areas that are susceptible to atrophy for whatever reason, be it age, be it Alzheimer's, be it diet, are protected by exercise. So maybe there's some aspect of clearing out beta amyloid plaques, maybe that's linked somehow to preserving brain tissue, or maybe there's another mechanism that independently preserves brain tissue. But overall, this is a really nice finding if you think that the more nerves, the more synapses, the more likely it is that you can coordinate those neurons and fire appropriately to remember things, speak and execute tasks appropriately. But what's not convincing about this is that this is one of those cross-sectional snapshots in time. These are older adults and older adults with varying levels of fitness, and comparing the structures of the brain between the two. There's no cause and effect or longitudinal element to it. But even if we extend this out over time, we can bear out some structure differences in the exercise versus a control or a stretching control group. And so one of the usual suspects that we saw in the last series, the hippocampus, which we know is intimately related in the development of depressive symptoms, here tends to decline over a year in individuals that don't exercise and is boosted or bolstered in those individuals that do exercise. So we see tangible changes over time in response to exercise that I'm not showing you, that correlate with memory performance, which may or may not be Alzheimer's, that correlate with changes in VO2 max, and interestingly, correlate with changes in BDNF as well, one of the neurotrophic factors we discussed in the last section. So in older adults, where you would typically expect the brain to atrophy, or specifically the hippocampus, we can preserve or protect against that with exercise, and we get the added benefit of improving fitness, improving memory, and increasing circulating BDNF. We don't know if BDNF made this happen. We don't know if the increase in hippocampal volume allows for more BDNF to be produced. We don't even know if they're related. But all these things happen together, which is a pretty nice constellation of findings, especially if you're an older adult that's worried about decreasing cognitive function. Then you can bring up the typical criticisms. We're not sure if diet was controlled very well or what the exercise adherence was. Regardless, the two groups, as separated, seem to exhibit some convincing changes one way or the other. So some of the tangible links to Alzheimer's, or some of the observable changes in the brain, seem to be improved. What about those individuals that don't care about proteins and tangles and circulating beta amyloid? What if we just want to know how cognitive function changes, if memory is impacted, if you can keep your marbles, for lack of a better word? What about those questionnaires and the mini mental state exams? Can we extend changes in brain tissue or changes in biomarkers to function at the whole body level? And this is what we're trying to get at now in this section. Can we compare a control group versus exercise, and what does it look like to say memory performance improves? This is meta-analysis, large collection of a number of different studies, 140-something different studies, with questionnaires or assessments of executive function, controlled task performance, spatial awareness, and processing speed or reaction time. And in all studies, those that exercised showed a larger effect, a more convincing improvement in all of these aspects of what I'll call cognitive function. And it's not satisfying. We don't know a lot of details about the exercise. We're going to assume it's just 3 days a week, moderate intensity. You can't really, it's really hard to do that with a meta-analysis, but those that exercised versus those that didn't showed improvements across the brain, we'll put it that way, universal improvements in function. But maybe it's because these individuals are healthy. I wonder if unhealthy or individuals with cognitive decline already are more resistant to this change. Does this mean that you have to start at 50 and keep exercising for the rest of your life to reap these benefits? No. So we see an improvement in cognitive function in healthy elderly and also in elderly with Alzheimer's disease. And these results, I almost am skeptical still. They're a little too good to be true. With only 3 weeks of exercise testing or exercise training, universal improvement in various aspects of cognitive function. So here we have attention, verbal recall, supraverbal, I don't even know what that is. The mini mental state exam, though, is one that we talked about before. Remember, a score under 23 indicates compromised mental function. It's used to diagnose Alzheimer's. Both time points, still compromised, but we see an improvement after only 3 weeks in individuals with Alzheimer's. So perhaps if you carry this out a little bit further, maybe these benefits will continue. And we do that. We've seen that over 6 months. These are examples of various tests. The Stroop is one that I showed you already, so you have an idea of what the Stroop test is. The Trails B test is a piece of blank paper or a piece of paper that has letters and numbers arranged randomly, and you have to draw a line between A1, B2, C3, D4. And this is time to complete that test. What we're looking at here is the change from baseline over 6 months in a control versus an exercise group. Now this is different than what you have in the slides that were posted. This was incorrect in those slides. This said baseline versus 6 months, I think. That's wrong. These are changes from baseline in a control versus exercise. So in all the control groups, in men and in women, performance got worse. It took longer to do the Trails test, and then the latency, the delay in responding to the Stroop task increased. So performance got worse from baseline, it increased. In the exercise group, the opposite was observed. Everything improved. All the responses were faster. Time and delay went down. Now only Stroop performance in the women was statistically different, probably just because there's a pretty wide span of error bars, a wide distribution or scatter of these results, but they're all going in the right direction, which is promising. 6 months in individuals with mild decline improvement in the Stroop and the Trails B test. There's some other tests as well which improve overall pretty nice benefit of exercise at the whole body cognitive function level. 6 months isn't that long. The longest study that I could find was a 6-year longitudinal study. In older adults, so 65 or older, healthy older adults that aren't compromised, which you could argue is not the population of interest. You might want to see if exercise can recover cognitive function, not necessarily preserve, but either way, this adds to the information, adds to the case we're making for exercise and Alzheimer's. Not compromised older adults, and I do want to point out here that the tertiles that we're breaking these into, low, medium, and high fitness, which is going to be important in a second, do have different ages. So the least fit individuals are the oldest, which will come up in a second. So we're looking to see if exercise over 6 years in these individuals can protect against cognitive decline. So we're 66 to 71, 72 years old now. After 6 years, you're 72 to 77. you're expecting cognitive decline to occur, and you're looking at the rate of decline. So you don't want decline to happen. If anything, you want an improvement to occur. But we're looking at the slowing of cognitive decline over 6 years in this study. And what we observe is that in those individuals with the lowest fitness, cognitive decline was largest. Their cognitive function decreased the most. And there's a nice progressive stepwise reduction in that cognitive decline with higher fitness. So a 6-year longitudinal follow-up, assuming self-reported physical activity carried through for 6 years, the most active and most fit individuals saw the least amount of cognitive decline. But we haven't corrected for the fact that the individuals that were the least fit are also the oldest. They probably have the most advanced cognitive decline to begin with, or they're most susceptible to cognitive decline. So maybe this isn't an effect of fitness per se, and just an effect of them being older. Of course, their cognitive decline will accelerate if they're older. When you correct for that, when you standardize for age using statistical magic, age-adjusted 6-year cognitive decline still exhibits the same pattern. Highest reduction with the lowest VO2 max, and a nice progressive reduction in that cognitive decline, or preservation of cognitive function. We don't know why, and we're actually not even convinced that this is meaningful. I'm kind of skeptical of what it means to see a 0.6, a decrease in 0.6 of the score of the mini mental state exam. On a 23-point scale, what is a change of 0.6? I don't know. Relatively, of course, it's better with higher fitness, but is this borne out in anything? Does this mean that a free-living individual going about their daily life will observe tangible benefits? I don't know the answer to that. But certainly rationale for exercise to exert whole brain effects or whole brain improvements to protect against decline, to improve some of the biomarkers that we're pretty sure are involved in Alzheimer's disease. And as we unravel the pathophysiology further, and we start to explore things like oxidative damage, we might have a better sense of why exercise works, but we see that it does, even if it's a small effect. So I'm going to leave the exercise and cognitive decline there for a second, but one thing that my mom always asks me about is brain games, lumosity, things like that. She does them avidly. She doesn't want to experience any cognitive decline, as I imagine we all won't when we're older like she is. She's like, what about these brain games? Do they work? And so, as a little addendum, a brief point about brain games, which I'm affectionately referring to here as just a brain game. But this is cognitive exercise, not whole body exercise, cycling, running, walking, weights or resistance bands. This is thinking type exercise, which, if you consider the brain is the symptom, the brain is the cause of the problem and Alzheimer's is the symptom. If you can work out the brain, maybe you can protect against Alzheimer's. Maybe. Maybe there's other underlying root causes that you can't address with just brain games. But the big concern is, does doing calculation, does practicing reaction time translate into anything? Does it help you follow a recipe better? Does it help you pick up your kids or carry groceries into your house or wash the dishes? Does it transfer? Far transfer. That's the paradigm I'm describing. That's the issue in this area. We have little ability to measure this. It's hard to measure far transfer. We don't have a standardized test like with the mini mental state exam to measure cognitive decline. it's hard to extend these results to some other task. But in the research that's out there, and I used to have more, but I'm going to go through just a couple of brief points. It seems that complex games are better than simple games. So things that involve planning and strategy are better than reaction time. Probably because they involve more areas of the brain or more aspects of cognition and might provide a larger stress. At least that's my theory. If you only practice reaction time, hitting a button when you hear a buzzer, it's debatable whether that's going to help offset Alzheimer's and cognitive decline. So in one of the only studies that I can find that looked at this, performance of brain games, using lumosity, which is probably one of the more popular examples of this type of material, I'm going to show you changes over time and baseline performance for people across different ages, 20 to 70. And the types of tests we're looking at are shown here. I don't know if you've ever tried lumosity before, but it encompasses a wide range of different tests. So this is a series of symbols, and you have to, as a new one comes in, they shift to the left, and you have to determine whether or not these two match up. Yes, you click yes, they match. No, you click no, they don't match. And then you do that as quickly as you can. Or you're shown a pattern in red squares that disappears, and you have to click all the boxes that were highlighted previously. In arithmetic, you have to type in the numbers that correspond to the solution in each of these bubbles, and when they do, they pop. If they land on the water, I think you get a strike or game over. I can't remember. And then over here, verbal fluency, you're given the root of a word, so this is STA, and you have to type in words that begin with STA. Stadium, star, and that's the only two that I can think of right now while my cognitive function is busy with other things. Stable, statutory, I don't know. So these are the types of cognitive tests that you're doing with a program like Lumosity. So you're practicing these types of calculations. And across the board, what you might expect is observed. The performance of these tests is worse as you get older, which might be evident of perhaps cognitive decline in older individuals. So baseline score, and the scores don't mean anything, but we're looking relatively. A higher score is better. Younger individuals did better on working memory, spatial memory, arithmetic, verbal fluency, and then older individuals did worse. Performance of these tests is as you would expect. And the score is not really meaningful, but the change is what is meaningful. And that's going to come up on the next slide. So these are baseline scores. And the change over 25 days is shown here. So anything above 0 is an improvement. Everybody improved. You do 25 days of arithmetic, 25 days of spatial memory, everyone improves. In things like arithmetic and verbal fluency, everybody improved equally. So doing those types of tasks, doesn't matter how old you are, you seem to improve by practicing those types of tasks. But working memory, which is a very complicated test if you've ever done it, or spatial memory, less complicated, but perhaps more so than just arithmetic. We see larger improvements in young individuals, so there's some resistance here in the older adults for some reason. A smaller improvement over 25 days. All improved. Complex tasks improved more in the young versus the old individuals, so there's some resistance with age. But I'm hard-pressed to even know what this means. What does this mean? You got better at arithmetic. You got better at spatial memory. The far transfer obviously is lacking here. Does this mean you can carry your kids better? Does it mean you can get into and out of a car more easily? We have absolutely no idea. There's no convincing evidence to link things like this to improved real-world cognition. And that's how I'll describe not test performance. You get better at the test, and so your score goes up, and you want to pay your $100 a month or a year or whatever it is to stay signed up. There's no evidence to suggest that it helps you in the real-world scenario, though. Yeah.
I was even just gonna mention that, like, the younger the individual, the more familiar you are with the technology that you're using.
Absolutely.
Well, and that could definitely impact the scores in the older population.
Fantastic.
Not familiar with iPhones, laptops.
Yep.
or-
Great point. Great point. The medium absolutely will come into play as well. Yeah. Let's just summarize. How about that? There's a few more slides which are essentially asking, is it safe to exercise? So what I'm doing here is making a case for not just doing iPad-type tests or cognitive tests. You need to move around. Is it safe for compromised or impaired adults to exercise? The answer is yes. I'll just leave it at that. The answer is yes, with proper supervision, without any extreme, what's the new thing, Vinsanity or Tyvo or P90X, without any extreme modifications. Absolutely, it's safe for older adults to exercise. And so these benefits can be observed in older adults. Exercise can confer a benefit if they participate in exercise. So what do we know? Alzheimer's, difficult to characterize, even different to differentiate from dementia, but we have a few candidate tests that we can use to evaluate function. So biomarkers like beta amyloid, hopefully in the brain, hopefully as plaques, but we can also observe this circulating in the plasma and maybe draw some loose conclusions that way. We can measure cognition in a number of different ways using a number of tests, but I think the one that most agree on is the mini mental state exam, and we can correlate those with changes in actual structure of the brain using some new in vivo imaging techniques or functional MRI, which were the color density scales that I showed you before. So you can try to approximate and piece together a response that way. But overall, exercise seems to improve cognition. It does it in healthy individuals. It does it in compromised individuals. Cognition is improved. And whether your baseline is low and it's a recovery, or whether you're normal or not impaired and it's an improvement, it doesn't matter. It seems to work in everybody, which is really beneficial. We're not sure why. There's some suggestion that exercise reduces the amyloid burden. There's some suggestion that the brain structure is preserved or bolstered. There's some suggestion that even in the face of these genetic deficits, exercise works, but it's not the whole story. We don't know what the mechanism is. Or for that matter, if there's one mechanism. In fact, I'd say it's likely it's not. It's not likely there is one mechanism. It's more likely there are multiple redundant pathways or contributing factors. As the field advances, we might have a better sense of what the mechanism is, but perhaps we don't care as much as long as the whole brain function, whole body function is improved. Whether the mechanism is involved or not, we observe an improvement, but it's important still to note that it doesn't prevent the eventual decline. And we only have this with the incidence of dementia. We don't know if you can fully recover mini mental state exam performance or be remiss from Alzheimer's. I don't think that's a thing. I don't know if you've observed that. But there's still a progressive decline in function, even with exercise. It's just delayed. The onset is delayed. The absolute floor or endpoint is improved, but cognitive decline still occurs. And the last point, which we've already talked about, that's not a huge part of the section. Brain games don't seem to be exercise. They're not interchangeable. Whole body exercise is preferred. We don't have a whole lot of evidence to suggest that brain exercise in and of itself confers the same or any benefit. Physical exercise is required, at least from our understanding at this point. Which is good because the papers this week are physical exercise and Alzheimer's. Randomized control trials. I think there's a brain structure in there as well. Anyways, pretty cool stuff this week. And I won't spoil it by getting into them right now. Any questions before we call it? Yeah, don't.
Just with the papers, are we being tested on the papers as well? Findings on the papers?
So would any of the main messages from the papers be on the final exam? Sure, if you want to, yeah.
Not necessarily the main findings, but like details of the papers that could be like.
Details, I would say no. The paper exercise is more to test your ability to interpret and then translate.
Okay.
The main messages will agree with what we have in lecture, but I'm not asking you what the exercise protocol was or how long it was or what was the magnitude of the change or percent change. None of that stuff.
Would you give us a paper in the exam to evaluate?
Ooh, that's a good idea. Would I give you a paper to evaluate?
I think that'd be cool. I don't know.
Yeah,
Street
yeah.
foot rotation and stuff. I'd rather do that.
You know,
True.
that would be pretty involved. What I do like to do is put figures on. I really like that. Your ability to interpret figures, plain and clear, what the figure says, and not try to draw in all this other info. Just be concise and tell me, well, this shows X or Y, 1, 2, 3 different findings. I like doing that. So I might put a new figure on the exam and ask you to tell me, okay, what does the figure show? Let me just say, if that happens, don't try to bring in a ton of other information. I want you to tell me what the figure shows. I don't want you to say, it relates to this other study that we looked at. I just want to know that you can decipher a figure. Okay?
Clear, concise, clean cut.
Clear, clean cut. And I might give you a preamble. I might say, like, in this study where this, and this were the situation, we observed this. Tell me what it means. And we'll go from there. Okay. Great class.